morning, everyone, and welcome to the Forum at St. Bart's. My name is Peter Thompson, and I'm the Associate Rector for Formation and Liturgy here. And I'd like to welcome you to this conversation with three world-class medical experts within our own community about COVID-19 from a medical perspective, now that we are a few months into this pandemic. And they are going to answer your questions and talk about where we are as we look at ending the lockdown and reopening New York City. With me today are Dr. Jamie Ferrara, Dr. Jim Marion, and Dr. Peter Scardino. Dr. Ferrara is the Ward Coleman Professor of Cancer Medicine and Director of the Center for Translational Research in the Tisch Cancer Institute of the Icahn School of Medicine at Mount Sinai. He specializes in bone marrow transplantation and held leadership positions at the Dana-Farber Cancer Institute in Boston and the University of Michigan in Ann Arbor before coming to Mount Sinai 6 years ago. Dr. Jim Marion is a professor of gastroenterology at the Icahn School of Medicine at Mount Sinai, where he has been for over 25 years. He focuses on disease like Crohn's disease and ulcerative colitis, as well as cancer prevention. And Dr. Peter Scardino came to New York over 20 years ago to chair the urology department and head the prostate cancer program at Memorial Sloan Kettering. For over a decade, he served as chair of the surgery department. And since stepping down from that position, he continues to teach, see patients, and lead a broad program of research focused on improving the detection and treatment of prostate cancer. We are so fortunate, again, to have these three gentlemen within our community, and we are very grateful to them for their generosity, not only in helping us stay safe behind the scenes, but also in being here with us this morning to share their expertise with all of us. So thank you all for being here. Dr. Ferrara, great to have you. Dr. Ferrara, let's start with you. Can you just share some basic info about what this virus is and kind of where we are right now in monitoring its spread and testing for the virus?
Right. Well, the first thing to note is that COVID is primarily a respiratory virus that is spread through droplets and aerosols. It is a new virus in terms of human contact, so no one is immune to it before seeing it. It's not the common cold. Now, one of the big problems with our information about this is that the modes of communication that would normally be in place have been quite from the CDC or from other government agencies has been quite fractured, and you get a lot of different opinions about various things. So let's just start with some basics. So the first thing is that, is the virus alive? And the answer is sort of. A virus is a Trojan horse. It can't work unless it gets inside of a living cell. So in that way, it's different from a bacterium that can sort of lurk in water or in pipes or in other places. A virus can only live inside a cell and take over cellular machinery. So in that way, it has to get into the cell. And when it does, it replicates and then it spreads itself and goes elsewhere. The body eventually becomes immune to it, and there's a complicated immune reaction. But one of the ways in which we develop that immunity is through an antibody. So the immune system recognizes the virus as foreign and then decides to eliminate it. So when you get a test, there are two different kinds of tests. The first is being tested for the virus itself, and that is a swab test, and that is something that can be done with usually something that's brushed against a mucous membrane, like the nose or saliva. And that is the virus active in your body? Is the virus replicating? The second test is an antibody test. That must be a blood test. And that is to see whether your body has responded to the virus. You had it, you got over it, and now you have antibodies to it. It doesn't necessarily mean that you are immune to it. We'll talk about that maybe a little later. But it does mean that if you saw the virus, your immune system reacted, and now you have some level of protection. One of the big questions here is, where are we in the overall pandemic? And you hear about waves. Most of the information that we have comes from other pandemics that have occurred in the last 100 years. And so that's where we look for information about where are we now and what is the future going to be like. From my reading of multiple sources, we are still within the first wave. If this is a baseball game, other people have used this analogy, we are at the latest at the bottom of the second inning. We are not anywhere beyond that. So when people talk about second waves and is this coming, is this here now, that is not true. We are still, what has happened is that different places of the country have seen the virus spread initially more quickly. So here in New York, we were overwhelmed. We seem to be at the end of the first wave because of the aggressive social distancing that we've done. But places like Florida, like Georgia or Arizona, where it's increasing, this is still increasing in the first wave. So when you look across the country, what you'll see is that the number of new cases in the country is essentially flattened out at about 20,000 a day. That's because the cities that in the Northeast that were largely hit early have decreased to very small numbers, but places where there was very little in the beginning, and now, unfortunately, where social distancing has been somewhat, if not abandoned, at least less restricted, those places are seeing increases. But this is an increase really in the first wave. So let me stop there. I think that's a good place to end this first part.
Great, thank you. Dr. Marion, I know that you were on the front lines treating COVID-19, and I'm wondering if you can talk a little bit about what that experience was like and what you saw on the front lines.
Yeah, we were in California in early March when I got a phone call. We were vacationing and got a phone call from my chief of my division in gastroenterology that I was going to have a career change. And my career change meant that I was no longer going to be treating patients primarily with Crohn's disease and ulcerative colitis and all my teaching duties and the like, and that I was going to now be a COVID expert and run a COVID unit on the inpatient teaching service at Mount Sinai on one of the first 12 teams that were being established. So to give you an idea, Sinai is typically about a 1,600 bed hospital. That's our capacity. And there were no COVID teams at all when we started. We were among the first 12. And we had really no known COVID patients during the month of February, although now in retrospect, we know that they were there and infecting our staff. And we went from really none and 12 teams sort of being assigned. I had a 14-bed unit and 3 house staff, and we were on 4 days on, 4 days off. It was quite intense. And we went up to over 2,200 patients, COVID patients, from 12 teams to 32 teams up to 52 teams, all at the front lines. And some of you may recall that we didn't just have patients in our own building. We doubled up all of our ICUs. There were no more elective cases. Everything stopped except for caring for these COVID patients. And we even had tents set up outside. We were moving patients to the Javits Center at one point. So it was, especially early April, it was rather hot, if you will. The virus was circulating widely. And I would add to Jamie's comment that it really just needs people to transmit. It's, you have to view it like a toxin meaning it's dose related. The more exposure you get, the more likely it is to sicken you severely. And we had PPE issues initially. We had to push back to get the proper PPE for all of our house staff and physicians, but we were successful. And as a result, our overall infection rate has been close to zero at Mount Sinai. The main experience that I can recall from this, or the most searing memory, was that the patients that we were seeing, and again, it was a 29-step protocol to put on the PPE. We were very, very careful because, one, we didn't want to infect anyone else. I didn't want to bring it home. We didn't want to infect our colleagues. But you would go into the rooms, and the patients, to a patient, were terrified. And think for a moment, they have televisions in their room. So they're getting all of their COVID information from televisions telling them that they have a fatal illness and this is terrible. So they're feeling stigmatized, they're feeling terrified, and maybe even terrorized by their screens, small and large. And into that COVID cloud, we would walk every day. And the patients were incredibly grateful to have us there. But remember, they're alone often, or they're in a room with one other COVID patient. It was a harrowing experience for the patients. And I was extremely grateful for their confidence and trust that we would care for them. We knew very little about how the virus behaved clinically. We had some observational studies that had come out of China from their original experience, but even there, that it was clearly a very complicated pathophysiology, meaning it's very different from just being exposed, asymptomatic, to folks who were having really no symptoms other than their kidneys have failed, or they're having pulmonary complications, or they're having other vascular complications. They were having heart inflammation. So there were many different varieties of COVID-19 illness, and we were learning as we were going along. We were setting up clinical protocols to find out which medications, if any, would work. We had 12 protocols at one point, and we're actively enrolling patients, and those results should be coming out as we go through. At the same time, we had to teach the house staff how to manage these very complex cases. But most importantly, we had to care for these terrified patients and overcome our own dread. Now, it's easy, because at St. Bart's as a resource, I knew to go to Psalm 91 every morning, and that made it a lot easier and alleviated a lot of my own dread. And I know the dread that my family had about my going in. But once I had the confidence that the PPE was keeping me protected, that helped. But the St. Bart's community and everything that I've learned in that building helped immensely. Anyway, I'll stop there. I don't want to go on for too long on this, but it was very, very challenging. There was a lot of dread at the beginning, and it wasn't just giving patients medicines and support. And I think we did very well. Our overall death rate was quite low compared to many other countries at Sinai. I think the care that they got was exceptional. But the most common complaint I would get was, I can't breathe, or I'm thirsty. And I'm going to tell you, when you hear those words, like I did on a Good Friday's different when you hear it coming from someone who you can help.
Thank you, Dr. Marion. Dr. Scardino, I'm wondering if you can talk about how treatment for other health conditions happens during a pandemic, and specifically when elective surgeries should start taking place again, and how safe it is to visit a doctor.
Thank you very much, Peter. I'm delighted to join you this morning. I'm going to speak mainly about surgery, since that's my background, but I think some of the things I say are going to generally apply to many other health issues. The bottom line I hope we can communicate this morning is that if you need surgery in this time of the COVID epidemic, you should have it. It's very important to carry on with your essential medical care. We're all concerned that that the visits to doctors, even to the emergency rooms, hospitalizations, even calling the ambulance for an urgent medical problem are all significantly decreased for problems other than COVID. I think there is a great concern about coming to the hospital, and I want to reassure our group this morning that it's every precaution is being taken in hospitals. As Jim Marion just said, we've learned a lot by our several months exposure to taking care of COVID patients, and the environment is very safe nowadays, in spite of the continuing COVID epidemic. If you think about it, surgical teams, everybody in the perioperative environment, perioperative means those doctors, nurses, staff who take care of patients before, during, and after a procedure, are highly trained in ways to prevent infections, not only from coronavirus, but for other causes. For 150 years now, since Lister developed the antiseptic technique, surgeons and proceduralists who work in the perioperative environment have learned how to develop techniques to prevent infections in the operating room. And if you're not a medical family, you've certainly seen a television show with doctors and nurses donning gowns, gloves, masks, frequent hand washing before and after any surgical procedure. And it's a culture that is indigenous to the operating room environment. In addition to that, in the COVID era, other measures are being taken to prevent complications from surgery, specifically related to COVID. Every patient who's scheduled for a procedure is screened with a detailed questionnaire about to elicit whether they have symptoms of COVID, whether they've been exposed to someone with known COVID. Tests are mandatory at our hospital for COVID, the diagnostic test, at least within 48 hours of a surgical procedure. And if you're in the hospital recovering from surgery, routine testing is done every 3 days of everyone in the hospital. So extra precautions are being taken, and the staff who care for you in the hospital also today in most hospitals have to fill out a questionnaire every day before they go to work, detailing any exposure they might have had or any symptoms that are a hint of COVID. And if anything on that, the first thing, if anything on that questionnaire is positive, you're required to stay home. You'll get tested, and until the test comes back negative, you won't come back to work. So it's a very controlled environment compared to what things were before. And I think you should be comfortable if a medical procedure is necessary. I think it's very important that you go forward and get it. If you look at routine visits to the doctor, these are way off as well. And I think it's again essential to continue routine medical care. If it's important, if you have a question, ask your doctor, is the visit necessary now? Can we put it off for a few months without any great danger? And also, I think it's fair for people to ask the doctor or the nursing staff in the doctor's office, what precautions are you taking in this era of the COVID pandemic to protect patients? And there are many different steps that are being taken, but it's fair to ask before you go in. One of the most important benefits that they say every crisis is an opportunity. And one of the good things that's come from this healthcare crisis is the use of telemedicine. Telemedicine had been hung up on the intense regulatory controls that prevented the routine use of telemedicine to come into medical practice. There are issues with regulations. Medicine is regulated by state agencies, so there were issues about regulations. Can doctors in New York see a patient in New Jersey unless without a New Jersey license? Or do you have to have a license for every state you see a patient in? There were regulations about billing. Billing was really very complicated and hard to get. So that although the technology for telemedicine has been here for some time, it really has not been used, except it's been used very little until all of a sudden we had this pandemic and the regulations were swept away. Billing was allowed, the technology has emerged, and now it's very easy to use telemedicine. In fact, at our hospital, we went from 500 telemedicine visits a week, a month, to 5,000 a week over the last few months. And everybody expects that a lot of this will continue, that much of medical care can be conducted by telemedicine, saving the patient the trip in and back, avoiding people sitting in the doctor's office for long periods of time. It's much more efficient for the patients, and the tools we have with telemedicine make it very satisfactory for the vast majority of medical care. Now, you can't do a physical exam, and there's things that do require face-to-face care, but a great deal will be done by telemedicine, and I think this will endure in the future. So if I can leave people with one message, if you have a potential serious medical problem or a need to see your doctor, you should do it and not delay. We're worried, particularly in the cancer world, about patients not having their mammograms to screen for breast cancer, their colonoscopies to screen for colon cancer, their skin checks if they've had a skin cancer, and these things cancer can advance and be more difficult to cure if it's not caught early. So we hope people will, with the right precautions, continue to get the medical care they need.
Thank you, Dr. Scardino. Dr. Ferrara, at your recommendation, we suggested that folks read the New Yorker article by Atul Gawande on the system in his hospital system in Boston, the four-pronged approach to kind of preventing COVID-19 from infecting the staff and visitors. And that four-pronged approach included hygiene, distancing, masks, and screening. Clearly, you recommended the article, so you thought highly of that approach. How do you think we can lift this lockdown and return to kind of a more open society?
Thanks, Peter. Yes, I recommended that article because Dr. Gawande wrote very clearly, I think, what most of the hospitals were doing as this pandemic unfolded. And as Dr. Scardino and Jim Marion have said, hospitals live in a culture of safety. In terms of infectious safety, it kind of starts in the sanctum of the operating room, but it spreads throughout the hospital. And we know what it takes to stop the spread of the disease. Jim Marion was talking about being in a cloud of COVID, but even when you are exposed every day, if you use these principles of screening and distancing and protection not only of yourself, but of each other, so that for example, that the hospital staff do not transmit an infection from one patient to another. We know how to do that. That is in the DNA of the health systems in which we operate. And now we have expanded that dramatically. So we can use all four of these elements. But the part of that article that I would very much like to stress, and which the other physicians have also mentioned, is the idea of culture. If you put all of these things together and you help each other remember to do them, then it is much more likely to be effective. For example, 2 days ago, I was leaving the hospital, and as I walked out the door, the security guard stopped me and said, "Doc, you forgot your mask," which I had. I had just forgotten to put it on as I was leaving my office and coming down in the elevator. And so he offered me one, and I thanked him profusely, because it's not usual that you get a security guard correcting one of the physicians in the place, but because the culture is such that we all protect each other, then that leads to a confidence that that we are all protected. And that is really the most important issue, that we are aware of these things and that we mutually reinforce them. So what Dr. Scardino just said was absolutely true, that many physicians are now worried about a second pandemic, which is non-COVID related illnesses that are preventable, or at least mutable, by early intervention. Cancer is a great example, but there are cardiac diseases. I mean, suddenly there are many fewer heart attacks than you would have normally expected in the last 2 months. That is not biologically possible. What's happening is that people are not calling or coming to the hospital or calling for assistance. The same thing with strokes. Strokes have not taken a vacation because we're in the middle of a pandemic. So when we start to look at this, we can see that the number of deaths, for example, in New York, is more than 7 times higher than you would have expected in this time, and less than half of that is actually directly COVID related. It's this pandemic of fear that has followed the COVID pandemic, but we know how to do this when we all work together. And Jim Marion's point that the infection rate among healthcare workers who are daily attending to COVID patients is actually less than the overall infection rate. So we can go with relative safety here. It's not 100% guarantee, but I'll make it up, 93.4%. I mean, it's very high. And we truly need to get over this fear of inquiring about appropriate medical attention, because it is also killing us, and we can and should stop that. So I recommend this article, but the take-home message is we know how to do this. Hospital systems in particular know how to do this. They have been doing it. We know how to make it work. If you've got a problem, call your doctor. And even if you're worried, text him. I mean, all of the telemedicine has changed in our practices in the last couple of months. And if you go to an emergency room, or if you were, for example, to come to Mount Sinai, you would see a radical change as you walk in the door. People are tested immediately. No one is standing close to each other. We have, if there are any worries about symptoms, those people are put to the side immediately. Most people coming to the hospital come now for a test before they come, so that they can know a day or two ahead of time that they are not infected, and that they are not going to infect somebody else. So we all know that. So we really have to put these procedures in place, and I strongly urge folks to get in touch with their healthcare provider about the usual issues that you would have, because most of us are not very good at self-diagnosing. And we should really leave that to the professionals, and we have safe ways of doing that.
Peter, I would echo what Jamie just said. I think the last number I put out there was that we had over 2,200 COVID patients at Sinai at one point. It is such a relief to report that the number of patients, active COVID patients that we have system-wide is now in the 30s or 40s. So the presence of the infection at our hospital, it's in retreat, and you will know the minute you approach the entrance at Sinai. We have markings on the sidewalk, we have ambassadors at every entrance who are there to reassure you on where to stand. Our elevators have instructions. And we're seeing patients. And I will say, we are seeing this effect where we had 3 colon cancers that I think if we had been able to get to these patients in March or April, they would have had a different outcome last week. I really encourage people to reach out to their doctors so that they can get their regular medical care taken care of, because I think that will be a major second wave here in terms of other illnesses. And the system we have up at Sinai, and I know they have set up at all the hospitals here in New York, are really there to protect not just the staff, but to protect the patients who come in, and I think they work.
I encourage those of you that are watching and have questions to send in your questions via the live chat function on YouTube or the comments on Facebook, or you can also email them to me at pthompson@stbarts.org. While we're waiting for those questions, I'm wondering, those of us who are on staff are very curious about when we might be able to have worship here again. We've heard other folks ask that question. Given everything you know about the trajectory of the pandemic so far, what do you all think about when large-scale gatherings might be reasonable?
Well, I'll start. I am not optimistic that we are going to have in-person large gatherings much before the end of the year. I say that for a couple of reasons. Now, this is my personal opinion, so it's definitely not dogma. But as I said earlier, I think we are at the end of the second inning of at least a 9-inning game, and could be much longer. We will not know about the whether there is truly a second wave. And a second wave, let me just say, a second wave is when, independent of social distancing, that the virus itself seems to hibernate for some period, as they have in other pandemics. It goes away by itself, and then it recrudesces. It comes back by itself without any change of human behavior. That's what we mean by the second wave. And most people who have studied this have said that there could be a second wave in the fall, and that the second wave, at least in several past epidemics or pandemics, has been worse than the first wave. So the virus comes back with a vengeance. It was kind of off taking a nap, a summer nap, and then is really very virulent. Even if it hasn't necessarily mutated, there's something about these respiratory viruses in the second wave that can be devastating. So I would be, we may be open for business in terms of some gathering in the fall, but I myself am not planning on going to something until I know that there is not a second wave occurring, and that may be a very late fall. I would be, as soon as I can get there, I want to, but I need to feel that it's both safe for me and for those around me. So the experts, just to say, think that this, without a vaccine, we could, the stretch of the innings could be 18 to 24 months. Vaccines could change that, but short of that, I think we are in for certainly not in the next several months, and maybe not until really 2021. That's my personal opinion.
I'm going to be a little more optimistic. Again, this is an opinion, a personal opinion, but I agree with Jamie that the ability to meet, and I'm going to just focus, Peter, on what we're all interested in, is when can we meet in a corporate fashion under the dome at St. Bartholomew's. My sense, at least most of the models are showing that we are going to be pretty much at 0 cases, hopefully by next month. And if you look at what happened in Hong Kong, when Hong Kong was decimated by the first SARS in 2003, it did hibernate and it did seem to go away. And they were able, with masking and social distancing, to keep it at bay so that it did not recur. I'm not saying that's going to happen here, but I'm hopeful that we will be able to meet again. It will not be meeting in the way we have met. And this is where Bill Tully putting in those great chairs will come in handy. We will not be sitting together. We will be with our families. I don't think we're going to be able to be serving the Eucharist the way we have traditionally. That will require better minds than mine in terms of what is actually allowed sacramentally, individually wrapped. I don't know. Dixie cups, who knows? I mean, I don't have a sense of that. I'll let you all figure that out. But I think the idea here that we could be together in some fashion, but certainly not the way we were worshiping before, is I'm hoping it'll be. But I think the phase 4. I always lose track of the phases that New York State has, but I think phase 3 is the museums, and phase 4 reopening, I think, would be worship. I'm going to say stay tuned. If July is as quiet as I hope it's going to be, if it really does go into full retreat, even without a vaccine, I think there will be some modified gathering that will be no more risky than hopefully getting on a subway, but will require masking and distance.
Yeah, I tend to agree with Jim on this. It might be worthwhile for us to begin to think about what it would look like to be able to open before there's a widespread solution to the problem of vaccine or a widely effective safe treatment. I think it's doable, but it's going to be complicated to work it out. But I think it's possible.
Great, thank you all. That's some good news. There's a question about antibody testing. Someone specifically asks about friends that she has who thought they had COVID, but the antibody test came back negative. I know there are also concerns about false positives. Do you want to talk any more about antibody testing and what that can and can't tell us?
So very briefly, the antibody testing is in general less precise than the actual viral testing, and there are a number of issues here. What the antibody test tells you is, are there antibodies in the blood to the virus? At the moment, what it doesn't tell you is, are they neutralizing antibodies? In other words, are they the ones that are guaranteed to stop infection? And there are both false negatives. There are more false negatives and false positives, probably more false negatives in the sense that the way this is looked at is not very precise at the lower limit of detection. So it's if you have a strong positive, that's good. That means you have antibodies, although again, it doesn't necessarily mean that you have neutralizing antibodies. And we don't know yet, because we haven't yet been able to test it. What does it mean for an individual? It is definite. Most people say, do not assume that a positive antibody test is an immunity passport, which means that you can't have any of the virus or spread it to anybody else. So until we have a little more information about that, it is quite possible that it is, but at least at the moment, we don't have that guarantee. So I think that the antibody testing in general is less precise than the actual viral testing.
And any other thoughts?
Completely agree.
Okay, so there's also a question about we've been engaged in the past few weeks. In some ways, the discussion about Black Lives Matter has supplanted the COVID-19, which was the focus of media attention for so long. But it was also pointed out all along that there were racial and economic disparities in terms of who was affected most by COVID-19. I wonder if you all have any thoughts. Did COVID-19 simply highlight disparities that were already there, or is there something special about COVID-19 that exaggerates those disparities?
Well, I think in my own experience on the ward and on the unit, I observed a distinct disparity in terms of it was disproportionately affecting people of color. It was disproportionately affecting the poor. In many times, there was an occupational component to it. I saw sanitation workers who had picked it up somehow in their work. And again, there is a greater representation there. A lot of frontline, what we would call frontline workers who are working either in fast food, very close to their customers in retail. Again, a higher proportion of people of color in those fields. The one that was starkest for me were the number of school teachers. Half of my service for the first 2 or 3 weeks was school teachers from the public school system. And again, we were very late in closing our public schools, but at the same time, the younger kids are probably asymptomatic reservoirs. And again, in our public school system, there is it's reflective of the proportion of people of color who live here in the city. And the other thing is living conditions obviously tend to be more crowded among poorer New Yorkers, and the ability to escape to one's place out in the East End or outside of the city just doesn't exist. And I would also add a fair amount of sort of misinformation or confusion about the information that was actually given. Go about your daily lives, that sort of thing. A lot of different voices. And I thought that was a very good New Yorker article that commented that when a politician is giving you epidemiologic advice, beware. And I think that a lot of the patients that I saw in the hospital said, I didn't know this could do this, or I didn't realize that I could give this to my grandmother. I had a mother-daughter in the same room at one point, and it was devastating. Again, I didn't realize I could give it to her. So yeah, I think there's, I wouldn't call it ironic that I can't breathe was something I've heard in both. And to hear it coming from a person of color who has a knee on his neck or someone who has a virus in his or her lungs, yeah, I think there is racism here that ultimately led to these outcomes. But that's a thought I had.
Yes, I agree with Jim. Certainly in cancer, and Peter Scardino may want to also comment about this, but we have known for a long time that outcomes in underrepresented minority communities are worse for the same kind of cancer, that the toxicities of treatment are usually worse in Blacks and underrepresented minorities, and that information is out there. And so, unfortunately, it isn't surprising. The COVID has been like this enormous stress test on the health system. And the people who are most vulnerable in general became most vulnerable to this. I do not believe that the poor outcomes among communities of color was because they received inferior care once they got into the system, but they have been marginalized in the system for multiple reasons, including some reticence to and distrust of medical systems among the Black community because of the Tuskegee experiment and those that terrible chapter in American medicine. So there's a lot of sort of distrust or ambivalence about getting into the system and what's going to happen there. And then when it's there's a big stress like this, then there was a much worse outcome. It's both economic and racial. Those two often overlap. But I think that this, in many ways, is an indictment of the lack of public health, the racism in public health issues that we have not really grappled with forcefully enough to make those changes. But I believe that this is actually a much wider problem, and COVID has just brought it into very stark relief.
We've pretty much run out of time, and I apologize to those of you who have sent in questions that we won't be able to get to. I'll ask one final question, which is there's some frustration about people who won't wear masks, specifically folks talking about other people in their apartment buildings. We saw pictures this weekend of lots of young people standing outside of bars with takeout service. We've seen lots of pictures in parks of folks not social distancing, not wearing masks. Do you have any recommendations for folks who are frustrated by their fellow human beings who are not adhering to these safeguards and guidelines?
Well, this has to do with developing a culture of awareness and practice. And Jamie gave that great example of the security guard who was willing to say, "You forgot your mask." It's become a touchy political issue, and that makes it particularly hard to have that culture where we're all in it for each other, and that will reduce the risk to everybody.
I think the idea here, Peter, is that if the frustration part of it, I completely get. And I think, here in New York, we honk our horns, we yell at strangers, we get yelled at by strangers. It probably doesn't help the situation to have one's mouth open and yelling, even if you have a mask over it. So I think the idea here is that we will have to encourage that culture. We'll have to live by example. I'm not wearing my mask for me. I'm wearing my mask. Having been in the rooms with the COVID patients, I kept reminding myself that I was wearing the mask for my family, for my neighbor. And that is a not unfamiliar source of frustration for anybody who's ever had to interact with humanity. I mean, you're a clergyman, Peter. You know how we fail. This is why the church is on 50th and Park. So I think the idea here is, I would advise, check your pulse, make it a friendly suggestion. And what I usually, and I've had many conversations with my neighbors here who did not want to wear masks uptown. And I said, the virus is like gravity. It's a force. It's going to be there no matter what you do. You may as well have a parachute and consider the mask your parachute. And that seems to land.
I think that's a great landing for the whole session.
Well, I very much appreciate you all taking this time. It's been a very busy few months for you all, and I really appreciate you taking this time to be with us. I appreciate you. What you haven't seen in the comments is that Dean also thanked you all, along with Catherine Belford Budd, for advising him on best procedures for the parish along the way. And we are so fortunate to have the three of you and Catherine in our parish. And to benefit from your expertise and your wisdom. So thank you all for being here today.
Thank
It was
you,
a
Peter.
pleasure. Thank you.
And thank you all for watching.